All right. Um, Welcome. I'm Kieran Zakaris. I'm the Director of Student Development and Programs with the University of Michigan School of Public Health, Office of Global Public Health. I'd like to thank you for joining us today for our Global Crossroads lecture series. Today's lecture will focus on the experience of a student that conducted research in Kenya as part of the Minority Health and Health Disparities Research Training Program, or MERT, which is funded by the National Institutes of Health and is managed through our office. Our Senior Associate Dean for Global Health, Dr. Matt Bolton, serves as the director for this program. MERT seeks to increase the number of underrepresented students trained in health disparities research and entering biomedical behavioral health careers. We work with U of M undergraduates, as well as post-baccalaureate, master's, and doctoral students from all U.S. institutions to increase knowledge on health disparities research skills within the global context, focusing on child health, maternal health, and global health. The program activities consist of a research preparation, training in health equity, a 12-week field research experience with established faculty to develop and strengthen research skills, and post-experience opportunities for facilitation of research, presentations, and manuscripts. This year, the MERT program had 8 students from across the US working in sites in Dearborn, Michigan, Chile, Indonesia, Thailand, and Lindsay is going to speak to our site in Kenya. We're also developing new sites in Fiji and Nepal. If you are interested in the MERT program, the application for summer 2024 placements is now open with a January 15th deadline for Chile and Nicaragua and January 29th deadline for all our other sites. If you're interested in the program and would like to learn more, I'll add our web address and our email address to the chat shortly and encourage you to reach out. Upcoming additional events by the Office of Global Public Health include our international proposal workshops, which are geared towards first-year Masters in Public Health students interested in applying for internship funding for travel this summer. Attendance at this workshop is required for students applying for funding from our office. I will also add those dates to the chat here, but there are several upcoming workshops in January and February. Our annual Global Public Health poster session is going to be in person this year in January 26, 2024. We also have our students who participated in the MERT program will also be participating in that event at the Michigan League. And then just a reminder to continue to watch for additional Global Crossroads lectures offered in the winter semester. I'd also like to let you know that we appreciate your questions. For Lindsay, we encourage you to add those to the chat and we'll pose those at the end of Lindsay's presentation. I would like now to welcome our speaker, Lindsay. Lindsay is a second-year MPH student in the Department of Nutritional Sciences. She's originally from a small town in North Dakota, where she first became interested in food and nutrition. She received her BS in dietetics and public health education from the University of North Dakota in 2022 and received her certifications as a registered dietitian and a certified health education specialist the same year. Her research interests are around the intersection of environmental health and nutrition and understanding and advancing global health equity and environmental exposures in chronic disease. She's currently applying for PhD programs and hopes to have a career in academia, continuing her research in the space of nutritional and environmental epidemiology. Thank you so much, Lindsay, for preparing this presentation for us. And please go ahead and get started.
Thanks, Kieran, and thank you everybody for having me. Yeah, I'm Lindsay. So this summer, through the MHERT program, I was based in Nairobi, Kenya. I did have some additional experiences like outside in East Africa generally, and also in northern Kenya that I'll go over. So I just wanted, the picture that I have here is a picture that I took from a car while I was in Samburu County, which is in northern Kenya, when I was doing some field work that I'll discuss later in my presentation. So like Kieran said, I just wanted to also give a little overview of MHERT, Karen summed it up pretty well. So it's a National Institutes of Health training program for underrepresented students in global research. The Michigan School of Public Health, our program, works with Michigan undergraduates and then post-bac, master's, and PhD students from anywhere across global sites. Current and previous sites include Chile, Dearborn, India, Nicaragua, Uganda, Indonesia, Thailand, Kenya, obviously. And then the site in Kenya is available for master's and PhD students for those who may be interested based on what I share or if they're interested in global health in Kenya. So the in-country partner for the Kenya site with MHERT is the African Population and Health Research Center. It's a non-government organization based in Nairobi. They also have a regional office for their West Africa division in Dakar, Senegal. Their focus is Pan-African health. So although they have base in Kenya and then in Senegal, they have worked with over 35 countries across the African continent. Although most of their work is concentrated in East Africa, and the projects that I worked on were centralized in East Africa. APHRC has 3 different program divisions for the work that they do. So they have a research division that's very broad and has several subdivisions that I'll talk about. They have research and related capacity strengthening. So this is the research activities that they do and how they can encourage and support African researchers, both like while they're in school at APHRC and generally with a lot of the, they do a lot of like workshops and curriculum to advance African academics. And then they also have a policy engagement and a communications team. So how can we apply the research that we're doing? How can APHRC advance policy and equity based on the research findings that they have and communicate that out to the African continent. Their research division has several subdivisions. So they have human development. Under this, they have things like nutrition and food systems, aging, health and well-being. So that's a lot of like healthcare and like very general well-being, population dynamics and urbanization. So like the effects of climate change, kind of tracking like human population, and then data sciences and evaluation. That was the division that I was under. And they do a lot of data harmonization, creating data repositories within Africa to, again, like give access to African researchers to advance the mission and the equity in these spaces. So I was a research intern on the data science program team. From my background, you probably heard, I am not a data scientist. I am a clinician and nutrition epidemiologist by trade, but I've done a lot of data analysis within my work and really wanted to get some machine learning experience that the data science team provides. So I was very grateful for that opportunity. So DSP is a team of data scientists and data governance officers who work on projects related to data harmonization and accessibility, machine learning analytics, and collaborations of multi-country health and demographic surveillance sites. So HDSS sites are kind of similar if you think of things like NHANES or CDC mortality and morbidity rates. So they collect a lot of robust information on specific sites in Africa. And with that, they have like a gigantic consortium with information from all of these sites that people can collaborate with. And so it's a lot of data. They work a lot with the HDSS sites to like harmonize this data and make it so that people can view it, do research within these contexts. So my position as a research intern involved me in several projects focused in East Africa. So with this, APHRC, because it's has so many broad divisions, they have so many research activities that they're doing. I ended up on several projects with different roles in each of them. So I have 4 projects that I'm going to go over. A lot of these are currently in working on publication, and so I'm going to be kind of intentionally vague about some of the activities that I'm doing, because I can't give the information on the findings that we fully have. But I just want to give an idea on the type of work that I did, based on some of the research that we were doing. So my first project was the prediction of population nutritional and health outcomes from supermarket data in Kenya. So there's a concept within global nutrition known as the nutrition transition. So the global nutrition transition refers to the spread of the Western diet, characterized by highly processed foods higher in saturated fat, added sugars, sodium. And so as this spreads throughout the global context, a lot of traditional food items that are seen as quote unquote healthier have been replaced in a lot of low and middle income countries, including Kenya. So Kenya has seen a marked increase in the number of supermarkets filled with more processed food products, and these have replaced open air markets. So open air markets include a lot of fruits and vegetables, unprocessed foods, and they've just taken over a lot of the traditional food items that people would create if these were more accessible. These types of markets were more accessible. Western diet patterns have been associated with increased BMI, various cardiometabolic diseases, including diabetes, non-alcoholic fatty liver disease, heart failure, things like that, and certain cancers, especially colorectal cancers. Kenya is experiencing an increased prevalence of these non-communicable diseases and an increase in population overweight and obesity. So there's a question of what is driving this, and do the increase in number of supermarkets and the purchasing patterns that people have when they're in the supermarkets relate to the increased number of non-communicable diseases in Kenya. So what the data science team wanted to do is assess Kenyan diet patterns using population supermarket data or individual supermarket data. So obviously there's a very complex relationship between dietary patterns and non-communicable diseases everywhere, and especially in Kenya, since this relationship isn't directly known at this point. So how might we assess Western diet intake when we have individual purchase data from these supermarkets, and how do we kind of characterize them to understand the nutrition transition and the impact of the Western diet on new diet patterns within Kenya? So there's in the project protocol related to the prediction of non-communicable diseases, I talked about 3 potential ways that they can assess diet patterns based on previous work that people have done, and then also my experience as a nutrition epidemiologist. So there's the NOVA classification, which is a measure of processed food intake. So they categorize by unprocessed and processed foods along a 4-item continuum. So having greater purchases of these processed food items would create a higher NOVA score and be indicative of a higher uptake of the Western diet. So if you're purchasing more processed food items, you're likely eating them, obviously, and then having a more Western diet pattern compared to traditional diet patterns in Kenya. So that's one option that I posed to them. There's also a concept of principal component analysis. So within this, natural diet patterns emerge from common factors. So this is an analytical tool, essentially, that you put all of this information in, and certain food products will group together in a way within these factors. And from that, you can kind of create your own designation of what like some of these Western diets look like. So in previous work in more Central America and Mexico, they've kind of categorized things by traditional diet patterns. So things that would, food products that are more associated with the diet patterns prior to the Western diet being introduced in these global contexts. Transitional diet, so something that has both traditional food items and also some of these Western diet food products in both. And then a Western diet pattern that kind of emerges with more heavily processed food. Things like alcohol is also associated with the Western diet pattern in PCA. So this is kind of using the information that we have, like, can we create some diet patterns that make sense to assess Western diet intake? So as another option that I proposed to them for an analytical tool. And then from their assessment, they wanted to look at, when predicting using predictive analysis, they wanted to look at individual nutrient intake estimation. So for this, they wanted to, for an example, like say if there was a 10% increase in added sugar intake over the 5-year time period that we have data for, how would that predict like non-communicable disease risk in 10 years? And if we keep seeing that increase, would we see a continued increase in those non-communicable diseases? This is, I kind of talked to them about how difficult this is with individual product information. It would require a lot of data harmonization, a lot of introducing nutritional information that may not be accurate for the global context that we're in, considering a lot of them are developed in the US. And they have a lot of like European food products that have maybe less robust information on nutrition based on their country requirements for what they need to put on their nutrition label. But this was something that they really wanted to look at and they had some information on. So suggesting the four nutrients that are associated with kind of Western diet patterns and kind of a proxy for that. So that's sodium, so higher sodium, Western diet. Low fiber would be less a Western diet, higher saturated fat, and then also higher added sugars. So this is data and analytic tool because they're using individual purchasing product information and applying it to a population context. But I just wanted, this is kind of the work that I did with them on how can we look at diet patterns based on what is feasible for them. So if there's more questions about this, I understand, because yeah, it's hard to kind of understand like the prediction analysis. So happy to take questions on this at the end. And then additional components of the project protocol, in addition to talking about data analytics and the types of dietary assessment using data, I also did a literature review for the issue of background. So again, talking about the nutrition transition in sub-Saharan Africa broadly, and then also specifically within Kenya, non-communicable disease prevalence in this region, and then the development of the quote double burden of malnutrition. So in a lot of the, low and middle income countries, they have a high prevalence of malnutrition, so undernutrition. And then as these Western diet patterns and things like overweight and obesity and non-communicable disease increases in prevalence, it's called the double burden of malnutrition because you're getting malnourishment on both ends for under and over nutrition. And then the background of dietary patterns on non-communicable diseases. So talking about the impact of the Western diet on human health. Talked about the data analysis plan. So the cleaning of the secondary data that we would get from these supermarkets, data harmonization, since we're collecting from a lot of different individual locations with the supermarkets, and then how we can use the machine learning prediction to understand population non-communicable diseases. And then we also talked about ethical consideration because we're using consumer information, and then study timeline and budget with that. So that was my first project. So essentially like helped develop the protocol for that, and that we're currently like getting the data, and working on some of that data analysis for that to understand our question. My second project was mortality in East Africa. So within global environments, there's a tool called verbal autopsies, and with these, they assess cause of death. So information from a relative or a caregiver is collected following a person's death. So a verbal autopsy is a detailed questionnaire about communicable and non-communicable disease symptoms, medical history, and then it also adds on the regional disease prevalence for things like HIV and AIDS and malaria prevalence. So the World Health Organization has a verbal autopsy tool that they used in global regions with high mortality and limited availability for formal autopsies. So very, especially used in highly concentrated population environments, like lower resource environments as well. And then with verbal autopsies, the gold standard is having a 2-physician assessment and designation of cause of death. So with all of the information collected from the questionnaire, 2 physicians decide on an ultimate cause of death. If they agree, that's the ultimate cause of death. If they don't, they bring in another physician as kind of a tiebreaker. However, you can understand like how much time, money, like they can't go through so many if you have somebody individually looking at these. So it's pretty time consuming. So there have been algorithms that have been developed to designate cause of death. And there are a couple developed using the WHO's verbal autopsy tool to create these algorithms. And they have been validated against physician assessment, and they have pretty good validity when compared to those. So again, they're a great tool to understand mortality and cause of death in these regions. So for this project, we were looking at the differences in cause of death for Kenya, Uganda, and Malawi, so 3 countries in East Africa. And from the information that we collected with the data analysis, I wrote the discussion and helped write the introduction, and also the methods for the verbal autopsy tool, like how they're used with the algorithms. So the rationale for differences in causes of death. So I did a literature review of differences in mortality rates between the 3 countries. So based on the information there, why were we seeing the things that we saw? So within these 3 countries, the Kenya site was a Nairobi informal settlement. Informal settlement, you may also, it's synonymous with slums, but informal settlement is the term that is used more often now. A region of peri-urban and rural Uganda, and then rural Malawi. So we have a very urban environment, very highly population dense. Peri-urban refers to, is there like a larger an urban center within like 30 miles of this region, and then rural is, a classic rural definition. So we observed differences in rates, and a lot of it was attributed to regional variation and urbanicity. So differences in HIV and AIDS prevalence, malaria prevalence, the spread of tuberculosis and other communicable diseases that are airborne, and then healthcare accessibility when thinking about urban versus rural environment. And also things like income, since in Nairobi, although there's greater urban centers and therefore more healthcare facilities, things like income and other accessibility create some of these disparities that we might observe. So this is currently, my colleague presented this at the conference in Africa in the last couple of weeks, and we're working on working on the manuscript for publication. So look forward to that. And then third project was morbidity in Uganda. So this was specifically just one country. So what are the reasons for visiting local clinics in Uganda was the question. So within the health and demographic survey sites, this is using the same site as the mortality paper, that peri-urban and rural Ugandan area. And so information on gender, income, education status, household size, age, the number of clinic visits over a time period, and rural status were used in machine learning models to find the probability of disease based on multiple factors. So within these models, there were like the most visits were for acute communicable diseases. So based on each of those, using machine learning, what was the probability of, say, like a 45-year-old female who has a household size of 4 and has been to the clinic 4 times. So kind of developing that using machine learning to develop some of the rationale on why people are visiting these clinics and who is kind of at greater risk for morbidity and seeing physicians and going to the clinic multiple times based on demographic factors. So like I said, most visits were for acute communicable diseases, different respiratory illnesses, gastric distress, and malaria. And from those, we developed machine learning models. Again, not going to be sharing those, but again, my role was understanding the rationale for differences and the policy implications that these might have. So understanding what is the relationship between education and disease, both in a global context and also if that is observed in this context as well. Increased age and mortality. So how do we care for a global aging population, and are some of these more acute illnesses affecting older adults in the same way that they're affecting other age populations, both in their morbidity and also their mortality? How does rurality influence both access to healthcare and morbidity? So things like healthcare and access to education, differences in the way diseases are spread, especially communicable diseases, and things like malaria. Are they more influenced in rural environments versus urban as vector-borne diseases? And then kind of both finding specific policies that address disparities. So looking at things that have been done in the African continent, in different similar income and similar environment as Uganda. And then also how can we, based on the information that we collect, what are specific policies or programs that the Ugandan government and local entities can develop to address some of the observed disparities that we saw. And then finally, this was more so of a project rather than I got the opportunity to do some child malnutrition field work. So I was grateful to be engaged in 10 days of field work within the Samburu County. So within this region, you can see the little map that I have. It's called USAID Nawiri. So USAID is a US-based global aid entity. So they're active in these 4 counties within northern Kenya. So I was in Samburu, but the project that I worked on was Samburu and Turkana, looking at child malnutrition in both of those counties. So on field work, they do a survey assessment, and then they also collect anthropometry from the mothers and the children. So we had 5 days of fieldwork training with our field interviewers. So developing and kind of working with the survey tool to make sure it's intuitive, makes sense for the context, and that everything runs smoothly. Since it's a very long survey tool, it's almost 3 hours, depending on the information provided by the caregiver. And then also making sure that you can see in the left-hand corner here, they're practicing collection for a child that would be standing here. So this would be a height collection. So making sure that the anthropometry collection will be done correctly, for both the caregivers and the children. So this is the field office for USAID Nweri in Wamba. So in Samburu, Wamba is kind of like over here. It's in East Samburu. When I was there, I was in Marilal, which is like in the central Samburu. So it's the more population dense and also the smallest for as far as land size. Whereas North Samburu here is a very large land mass, and it's even larger in Turkana. As you can see, it's a very large county, so there's a lot of differences in like access. Like it's several miles to get to some of facilities that would be beneficial for child malnutrition and getting access to food. This is one of the schools that they have in there in kind of an education area for their field interviewers. And then this was the field interviewers, along with the rest of my team here from APHRC. They gifted us some traditional Samburu beadwork. So that's what these earrings and also this neck piece is. So yeah, they were amazing. I was really grateful to get that fieldwork experience and kind of see primary data collection in action and kind of assist with helping with that, and also increase my understanding greatly on how these interviews and data collection is done out in the field. And then that's all of my work with APHRC. So I was, grateful to get on a lot of different projects, get a lot of different experiences with both the data science and also the field work was with the nutrition and food systems team. Although we did work, we also had a lot of fun. So I went with two other girls from MHERT. So on the right here in this picture, I'm not sure if you can see my mouse, but this is Jasmine, and on the left here is Rahilu. So we got a lot of different experiences all over Kenya. We went on safari, the Giraffe Center in Nairobi over on the right here. This is it's called Hell's Kitchen on the coast of Kenya, and then this is in Mombasa, also on the coast. So here's like the inlet to the Indian Ocean. I'd never been to the ocean before, so I was like, ooh, the ocean is pretty cool. And then we also got to do fun activities like zip lining on the weekends. So definitely got a lot of great research experience, and also had a lot of fun and got to meet a lot of new people in a global setting. So it's grateful for the networking at APHRC, but also meeting a lot of new friends along the way. So if there are more questions about like overall experiences, or like if you're in Kenya and need fun things to do, let me know. So that's the end of my presentation. I just want to acknowledge the MHERT team and the grant for funding me for this opportunity. I'm very thankful to all of APHRC, and especially the data science program and nutrition and food systems team for working with me, being very patient when I didn't understand things, and giving me lots of different opportunities to work on projects I was interested and passionate about. I want to thank the Office of Global Public Health faculty and staff, especially Kieran. She was so helpful throughout the entire summer in the process, and has continued to be very helpful as we come back and do some of these presentation type of work. Thankful for the staff and security at Owazi Place. So this was where we lodged. Thankful for Rahilu and Jasmine for being great partners in this great adventure, especially Rahilu for she organized a lot of the fun things that we did with her family. So I'm very thankful that she was there. We got to do a lot of fun stuff together. And then, of course, thankful for all the APHRC study participants, because without them, research wouldn't be possible. So thank you. And I welcome any questions that people have now.
Thank you so much, Lindsay, for sharing your research and your experience with us. It was really wonderful to hear all of the variety of projects that you were on and about the organization. A few questions have come in through the chat while you were speaking, so I'll get started with those, but encourage others to please feel free to send those along as well. We still have time. One question I think would be great to start with is if you can shed any light on how APHRC, as a Kenyan-based organization, collects and coordinates data from other African countries.
Yeah, that's a great question. So like I said, a lot of it is through the consortium with the health and demographic survey sites. So it's called the Inspire Network, is the large data science team that works with data with these different areas. As far as like individual projects in other continents, because APHRC is a Pan-African organization, they have individuals like who come from countries other than Kenya. So a lot of them are doing like actively doing work and interested in doing work in their home country. So that's where a lot of those kind of independent country projects come from. Yeah, as far as like other, and then also having the West Africa site gets them connected to Senegal, Ghana, and things like that, for them to continue work in that region. But great question. Yeah, they have a lot of data, so it's like, where are you getting all this? So
Another question that came through was, are Kenya and other East African countries dealing with increasing sales of sugar-sweetened beverages, which are one of the main drivers of childhood obesity in the US and elsewhere?
yes, definitely. So that's a big part of the nutrition transition is accessibility for sugar sweetened beverages. Um, like in the US, they're like often cheaper than other alternatives. Um, and even things like that are part of traditional food patterns, like they have a lot of fresh juices. As with the US, a lot of them are having added sugar brought into them as they're being packaged for shelf life. So yes, that's a major driver of the added sugars, and they're experiencing that as well, especially with sodas.
Thanks. All right. Another question is, you talked about malnutrition as including both undernutrition and overnutrition. What's the relative burden of each of these forms of malnutrition in Kenyan children and more generally East Africa? Is undernutrition more common than overnutrition?
That's a great question. Currently, yes. So undernutrition, especially with the child malnutrition fieldwork that I did in certain regions of Kenya, especially northern Kenya, they have almost like a 35% rate of child malnutrition for children under 5. So again, a major issue. Continual work needs to be done in this space. As far as the actual burden that overnutrition is having on like Kenyan disease, as I said, like they're starting to see a pretty dramatic increase in non-communicable diseases. That can likely be attributed to the overnutrition factor. However, it's unknown at this point, like how much of the burden. Their obesity rate is about, I think, 12%, compared to the US's 30. But especially for child malnutrition, Kenya is expected to have the highest increase over a 10-year period, of almost like a 12% increase in childhood obesity. So yeah, the burden kind of remains to be seen, but definitely it's really difficult to address both of these issues, which are both vitally important to Kenyan health.
So, do you see yourself working in Kenya or more broadly in Africa as part of your career in nutrition?
Yeah, I would really love to. This was kind of my first experience. I've had work in Central America prior, so I was really grateful to get a new perspective in Kenya and Sub-Saharan Africa. I would really love to. I think APHRC does amazing work, especially they're creating a new division of nutritional epidemiology. So I'd love to be a part of that in the future, and as they kind of continue to develop that. And I also, for personal interests, I think there's a lot of toxicants that are just not understood within this region, and it creates like a lot of the health issues that they're seeing, and it drives a lot of these health disparities. They're starting to do a lot more work with climate change at APHRC, and kind of bringing in that environmental component. So I would really enjoy continuing to work in this space.
What advice might you have for current or prospective students interested in global public health research or programs specifically like MERT?
Yeah, I feel like a lot of it is, I feel like networking is something that everybody hears and like really doesn't understand what it means, and it's really hard because you feel like you're being annoying sometimes. And so I think persistence is like a really big thing. Reaching out to faculty that you're interested in, different programs that you're interested in, because the worst that people can say is no. So if you feel like you're doing too much, you're probably not, unless somebody tells you. But that shouldn't discourage you from reaching out to other people. For MHERT specifically, yeah, I think like connecting with Kieran, especially if you're really new to research, don't have like a lot of background in this space, connecting with previous people who have been a part of the program, and with the program directors so that they can kind of give you some of that guidance. But yeah, if you have like a really specific interest, finding people, Michigan's a huge place, and they don't have to exclusively be in public health. There's the Global Health Equity Program Center. So if you have kind of broader questions outside of like public health or some of the work that you see people doing, you can always reach out to the greater network. Most people are really, almost all academics that I've worked with are really happy to meet with students and kind of further some of these health equities in the global context. So don't be afraid.
Great advice. And on kind of a similar note, is there coursework that you have completed that you believe help you succeed in this experience?
As far as Kenya, I don't know if there's like specific coursework that were beneficial. Obviously, with the supermarket project that I was having, like having a nutrition background and a nutrition degree was very beneficial for that project. But as far as like the other projects that I was working on, I didn't do a lot of data analysis. Depending on where you are, that may be untrue. So, or the work that you might be doing if you want to work with APHRC this summer. So I think like just really like nice like basic courses in the core, like biostats, epidemiology, just to kind of like a good basic background. And then I know there's some, not as much in nutrition, but I know in epidemiology there's some global health coursework. I don't know if those are open to non global health epidemiology students, but if there are, you should definitely look at those. I think electives like are really important to kind of like broadening your understanding, and especially if you have a specific interest, kind of taking advantage of those courses that are here.
Another question that came in is, when you were traveling in Kenya, did you see many Western fast food restaurants like McDonald's or KFC or others? And do Kenyans frequent those restaurants if you did see them?
Yes, Nairobi is often called like the New York of East Africa. It's 5 million people, and it's a very industrialized, westernized city. KFC is super popular there. Kenyans love KFC. That's like the number one like fast food that we saw. Um, so I think, yeah, especially like in the urban centers, that's where like, as I talked about the nutrition transition, it starts in those urban areas. So that's where observed a lot of like the fast food, and we went to like a lot of malls. Like there's a lot of malls in Nairobi, just to kind of like hang out and do a lot of just like, normal like activities that you would think like that you do here. obviously in like the more rural northern Kenya, didn't really see like any fast food. Um, and like accessibility just looks a lot different than Nairobi and Mombasa as well. So yeah, they'll if you're worried about like if you're like a picky eater or something and worried Nairobi might not have your favorite food, they definitely will. So
Thank you so much, Lindsay. All right, one other question that came in was, did you encounter any barriers to getting your work done while you were in Kenya?
a pretty big barrier was the amount of projects that the data science team has ongoing. And it was great because I got a lot of opportunities, but everyone was so busy all the time that I felt like there was like sometimes it was really hard to get like a meeting to either like update on some of the work that I found, or I really wanted to get some more data analysis experience with the machine learning. And it just got really difficult with like the time kind of setting up a meeting and kind of being shown the ropes. I think another thing as well is like a lot of people continued to work at home in the office, so we would go in, but it was like kind of had to set up and like make sure that somebody was going to be in that day. So yeah, it was mostly just the time constraints, which is it's research. Things move slow sometimes, especially with the. I was hoping to do some of the data analysis for the supermarket project, but research is slow sometimes, and the data didn't come in. So unfortunately, I didn't get that opportunity at that time. But yeah, just keep bugging people about if you are bored and need work to do, because that's what I did. That's why I have 4 projects. So
Wonderful. Thank you so much. I'll just do one last call out. If there's any additional questions, please put those in the chat. Otherwise, I thank you all for being here. Thank you so much, Lindsay, for sharing your research and your experience in Kenya with us. Much appreciated. Yes, and congratulations. All right, thank you, folks, for attending. We appreciate having you here and joining in.
thank you.